essentially is where that person's in their overhead squat. They go down into that squat and their ears start to show up, and you have those arms kind of falling down, right? Now, ideally, those arms should start directly in line with the body, so they should be in line with the torso and in line with the head. But obviously, in this picture here, you see those arms fall. Well, what we end up running into is oftentimes, if we have restriction in shoulder range of motion, that patient or client may not have even been able to get their arms overhead from the beginning. So if you notice that you tell them, okay, bring your arms straight up, and they bring their arms straight up and they can't get their arms all the way up overhead, that is still arms fall. So you would kind of notate that as arms fall even before they started squatting, right? And this is actually a nice sign, because if you have somebody who can't squat, is limited in squatting, isn't comfortable to squat, we can still identify restriction in upper body just by having them bring their arms up overhead, right? So you don't even need to have them squat to do this assessment necessarily, right? So, keep that in mind. If they can't get their arms up overhead at the beginning of the assessment, it is still arms fall, and you're going to mark that little box of, on that checklist. And this is, again, is our standard typical checklist, right? There it is, arms fall forward in that overhead squat. So we start thinking about, okay, we got that. Well, what do we do? What's the next step? And oftentimes we go, well, we got to do that other column there. We got to do the squat with modification. Well, the cool thing with arms fall is that there is no need for a modification. So arms fall and scapula elevate, right? There is no need for an overhead squat with modification, because we know those two dysfunctions specifically, or those two signs, are coming from upper body muscles. So we don't have to do any other modification to like hone in on where those compensations are coming from. We can kind of get real specific with it just from the traditional overhead squat, or just bringing your arms up overhead. So we can essentially begin the intervention right away. And if that is the big limiting sign that you see, we can just kind of jump right into it. So, which is nice, because now we can say, okay, well, let's start talking about that, breaking down that arms fall. What are the muscles that are involved? And we start looking at this as, when we see arms fall, we think about it as shoulder internal rotation. And I use shoulder internal rotation. It's essentially a restriction in kind of external rotation, is why they can't get their arms up all the way or maintain their arms up all the way. So a restriction in shoulder external rotation is really identifying an increase in shoulder internal rotation. So hopefully that kind of makes sense. Now, the cool thing is, as we look at shoulder internal rotation, they end up being, those internal rotators rather, they end up being the same muscles that do, for the most part, do extension of the shoulder. So, we start to see some parallels here with some of these big movers. So as you start thinking about these muscles, okay, what are my shoulder internal rotators? Well, it's things like, lats. The lats are a big driver to this gain. Lats little helper, the teres major, and then you have some other muscles that you may or may not have remembered back from anatomy, like your subscapularis. And then on the flip side, right, the underactive muscles, the ones on the opposite, the ones that are responsible for shoulder external rotation, or at least shoulder glenohumeral stability, end up being that posterior rotator cuff, like infraspinatus and teres minor. Those are the ones that are going to be traditionally underactive. Notice I left posterior delt out of here. So actually what happens with posterior delt is it becomes lengthened, but overactive. So it actually becomes an overactive synergist in this sign. When we see arms fall, we actually end up having post delt try and do the job of your rotator cuff in stabilizing the shoulder. And it's not a good stabilizer of the shoulder. Right? Your rotator cuff is a much better stabilizer based on the attachment of the muscles than your posterior delt. So essentially, if you're familiar with lower body, and the lower body dysfunctions that we've talked about in the past, your posterior delt is like the hamstring of the upper body. It's lengthened and overactive. Right? So that's why I left it off of that list. Now, as we start looking at this, we go, oh, okay, that's my list. That's my list of muscles. That's easy, just like every infomercial. But wait, there's more, right? So as we start thinking about arms fall and upper body dysfunction or upper body muscles, we have to start thinking about, wait a minute, there's some other things that are connected here. And oftentimes, when we see arms fall, we're also going to have a bit of a compensation, or we're also going to have a little bit more of some scapular issues or scapular dyskinesis as well. And what we're going to find is a kind of parallel with arms fall and shoulder girdle elevation, or we could call it scapula elevates. That's usually what I call it, just to like make sure there's no confusion here with certain muscles that might contribute to this. But usually when we look at somebody who's got arms fall, we also have shoulder elevation or scapular elevation as well, right? So these dysfunctions really kind of have to get us thinking. And it has to get us thinking on what are the muscles that would contribute to these some of these additional dysfunctions of, the scapular side of things. So when we start looking at scapula elevates or shoulder blades elevate or whatever you want to call it, that motion actually ends up being downward rotation and anterior tipping. So our overactive muscles end up being the downward rotators and the anterior tippers. Our underactive muscles are going to be the opposite, the upward rotators, or at least some of those upward rotators, and posterior tippers. And unfortunately, this particular compensation, or this particular sign of scapula elevate, is sometimes tough for people to see. So what I want you to think about is go back to the muscles that connect to the scapula. And I know that's a hard task because we haven't looked at that stuff in years. So I'm going to do it for you, right? So when we start looking at some of these muscles that connect to the scapula, what we have, obviously, this is your scapula, and this is an anterior view of the scapula. So we're going to I'm going to do my best here to draw some muscles and where some of these muscles attach. Well, we have our levator scapula. So here's our superior angle of the scapula up there. So we have our levator scapula kind of connecting from this way, right? And then we also have my rhomboids that are kind of connecting from this way. And I have my pec minor that sits here, kind of connecting from that way. And if you think about the direction or line of those muscles and how they pull, well, that's why where I drew the arrows, right? And I know it's not perfect, so excuse my Picasso-like drawing. But, and again, we think about this head of the humerus kind of fixed in that glenoid cavity. So that's not going to go anywhere. That's going to be kind of stable and stuck in there. Right, so that's not going to go there. There's big muscles that kind of lock that in. But if you think about that scapula now, what's going to happen with the pull of those muscles is we're going to get a little bit of that. Right, so we're going to you kind of see a little bit of more of that shift of, okay, this is where we start. But if we have overactive muscles that are pulling that scapula, like your levator, pec minor, and rhomboids, it can pull that scapula kind of down into that downward rotation. And obviously we'd have to think about the scapula kind of tipping forward with it. So we tend to see that motion there when we start looking at upper body dysfunction. So this would be, again, for somebody who had arms fall forward, scapula kind of comes up, crunching up over towards their ears. This is what we're getting. So that kind of shift down that way. Hopefully that's a little bit easier to see. and maybe a little bit helpful for you to kind of start putting some of these muscles together. And I know I just kind of gave them to you, but those overactive muscles are going to be rhomboid, pec minor, levator. Those are downward rotators. And then my anterior tippers are going to be that pec minor and levator scapula that can pull that scapula up and over and up and towards the ear. We have our underactive muscles that end up being serratus and low trap, right? And they both are my upward rotators that are underactive and my posterior tippers that are underactive. So now as we start looking at this arms fall dysfunction, I thought we were just talking about arms fall. Well, we have a little bit bigger list here when it comes to upper body dysfunction as a whole. So like I said, generally speaking, for people who have arms fall, you're going to get scapular elevates as well. So that's why I think it's a more inclusive approach to kind of address all of these muscles. And the big ones I left up here for you. So some of the other stuff I kind of left out, like pec major and anterior delt, and some of the teres major, I kind of left some of them out. The big ones that I think you're going to have the biggest kind of return on investment is going to be your latissimus dorsi, your subscap if you can get to it, your pec minor, your rhomboid, your levator. Those are going to be the overactive muscles. And then as it comes to subsystems, if you're familiar with subsystems or slings or whatever you want to call them, the subsystem that's going to be overactive is going to be that anterior oblique subsystem for the most part. So it would just allow us to I wouldn't want to incorporate movements or exercises that really emphasize that anterior oblique subsystem just yet, like rotational based movements. I'm going to minimize some of them, at least initially, until I can kind of tone some of this upper body dysfunction down. For our underactive muscles, what to address on the opposite side are really, a few muscles, right? My external rotators are my posterior rotator cuff, that infraspinatus teres minor, that serratus anterior, and that low trap. They're all going to work kind of together to kind of maintain optimal upper body alignment. And then as a subsystem approach, we have that intrinsic stabilization subsystem, and we have that posterior oblique subsystem that we can kind of integrate into our routine, just to kind of help make sure everything's kind of functioning and working as a whole, right? So hopefully that starts to make sense. And I'm sure you kind of have seen this. If we kind of think about some of these muscles, like we have lat overactivity from, just a lot of the position, that internally rotated position that you see people in. Subscap, if you've ever worked on subscap before, that's a muscle that tends to develop some pretty nasty trigger points. Same with pec minor, same with rhomboid, same with levator. Those are the muscles that end up having these tender spots, these trigger points that really cause or create some discomfort and issues in that upper body. And that can all contribute to a decreased range of motion.